Hello, everyone, and welcome to another installment of the Da Vinci Educational Series. This is Dr. Andrew Heyman, and this lecture is part 2 of the chronic inflammatory response syndrome. I hope you all have listened carefully to the first in this series because I think this is not only an important topic, but likely a new one for many of you. And there are some details there that are worth looking at closely. I will review some of the elements today before I get into the therapeutic sequence in terms of dealing with these patients and treating them based on a validated protocol. So chronic inflammatory response is chronic by definition. It lasts more than 6 months. The main feature of it is the inflammation that's generated mostly within the innate immune system, and the main defect or predisposing factor towards this illness is poor antigen presentation. So usually there is the presence of an allele on chromosome 6 with respect to HLA sequences that restrict the efficiency of antigen presenting cells in their jobs with respect to showing an epitope to a T cell. What this means is that this patient population gets stuck in their innate immune response. They're chronically inflamed, and this leads to a whole host of problems throughout their physiology. As a result, this really is a syndrome in the sense that because so many things can go wrong with these individuals, they tend to report a lot of different symptoms. Again, the foundations or pillars of CIRS in terms of our scientific understanding of the illness is based in a variety of clinical assessment tools and understanding with respect to this inflammatory response. And that includes an assessment of the patient's proteomics. This means the set of inflammatory proteins and transcription factors and neuropeptides that become abnormal in the setting of this illness. These are typically blood labs that can be drawn through most major laboratory companies. There's nothing really fancy about that piece of it, but oftentimes these are markers that are not familiar to most practitioners, which include things like TGF-beta1, C3A, C4A, MSH, VEGF, MMP9, so on and so forth. In addition to that, we also have a better understanding of the transcriptomics in this illness, and that is to say loss of gene regulation within very specific gene sequences. This then leads to unregulated inflammation in this patient population, and therefore the body sort of just runs out of control with respect to a persistent inflammatory response. As a consequence of that activity, this leads to abnormal immune functioning in addition to secondary and tertiary consequences, including hormone dysregulation, GI problems, chronic aches and pains, mood disturbances, cognitive decline, a whole host of issues. And even though this feels like a big beast in terms of both the underlying pathophysiology, the symptoms that are generated, and all the problems that accrue, it is incredibly common. And so much so that it's even surprising, I think, to practitioners when they get into it with these patients. And that is to say, up to 22% of the population carries the alleles on chromosome 6 that predispose them to this chronic inflammatory response. Again, this inflammation is first triggered by a biotoxin. That means that it's an organism or a part of an organism that turns on this immune response. This does not mean heavy metals and chemicals. It does mean bacteria, parasites, fungal elements, viruses, mold and mycotoxins, as well as VOCs and MVOCs and so on and so forth. So the list is long, and some of these items you might be familiar with, many you might not be, but all of it is to say that the core feature is an organism or a portion of an organism, such as hyphal fragments or cell wall fragments, initiate an inflammatory response. And in this vulnerable patient population, the 20%, they can't turn it off. And so this creates ongoing misery for them. And the misery comes in lots of flavors. So we know that there are 13 categories of symptoms in which symptoms can fall. And as part of our diagnostic criteria that I discussed in part 1, if a patient has at least one symptom in 8 of 13 categories and they fail their visual test, we have a 98.3% sensitivity that this patient is one suffering from a biotoxin illness. The main complaint is fatigue, but individuals can report a whole host of problems, including headaches, aches and pains, unusual sensations, breathing issues, digestive complaints, cognitive decline, mood instability, problems with weight gain, temperature dysregulation. So lots and lots of symptoms that begin to accrue with these patients, and everybody's a little different in how they express that. One individual might have problems with headaches and brain fog and memory loss. Others, it might be general aches and pains, shortness of breath, and digestive complaints. You just never really know with these patients. Again, the initial lecture for this topic, I reviewed the in-depth process of how do we diagnose these individuals. It is a stepwise protocol with respect to gathering information, organizing it, and making hopefully a definitive diagnosis. And so we gather both self-report data with respect to symptoms, as well as lots of objective markers that include not just the proteomics, but the visual test, as well as even cardiopulmonary testing, potentially the brain MRI with NeuroQuant. Transcriptomics right now is still for research purposes, but soon we'll make it commercially available, in addition to some of the other ancillary tests, such as looking for the presence of Lyme disease. Again, here are the HLA sequences. There are 9 of them on chromosome 6 that create the susceptibility where they have poor antigen presentation. So it's an inefficiency between the innate and the adaptive immune system. We've identified at least 3 gene sequences that have to do with multi-susceptibility, although I think we're going to be expanding this list. Some of the alleles are specific to the original exposure as well. So you can see there are several for mold, as well as Lyme, dinoflagellates, so on and so forth. Here's the results of one of the visual contrast studies. This is to say, as the brain becomes more inflamed, the patient loses color discrimination. And this particular individual failed the test. In addition to that, I also suggest you draw the proteomic markers. There's a variety of them that underlie this ongoing inflammatory response, such as C3a, C4a, MMP9, and TGF-beta1. Here we have the biotoxin pathway. And we know that all of this begins as a storm in the brain. So cytokines are released from microglial cells, which begin to alter how people feel. But ultimately, over time, these cytokines begin to injure areas of the brain, including the posterior hypothalamus. So these patients develop leptin resistance. That means it contributes to their significant weight gain, in addition to anterior hypothalamic function. So we see declining melanocyte stimulating hormone levels, as well as alterations with respect to the general functions of MSH that have to do with sleep, pain, GI function, immune strength, as well as balance of hormones in general. So there's a lot of problems that result because of low MSH. In addition to that, the sort of peripheral hypoxia, loss of VO2 max, declining exercise tolerance has to do with the capillary constriction. So there's poor blood flow to the periphery because of release of VEGF and TGF-beta1. In addition to that, some patients can develop pulmonary hypertension, and of course that creates strain on the right side of the heart, which is where they get their palpitations. As well, these individuals also progress to potentially either presence of autoimmune problems and triggering of the complement cascade, but in particular the alternate complement cascade that has to do with C4a and C3a, and then other inflammagens like MMP9 and PI1. So what are the labs that you may consider ordering? Well, your HLA sequences, as well as all of the proteomic markers, MSH, ACTH, cortisol, ADH, osmolality, TGF-beta1, VEGF, MMP9, D-dimer, anticardiolipin antibodies, leptin, C4a, C3a, as well as a full Lyme evaluation too. You'll also be swabbing your patients for MARCoNS. This is the multiple antibiotic resistant staph infection that can begin to harbor the deep nasal passages. This is due to a low MSH, so therefore the immune system is not as vigilant as it should be. MARCoNS is a biofilm former. It is genomically active, and that means it expresses inflammatory proteins that make their way through the olfactory bulb directly into the nervous system and further inflame the brain. So this is a bad actor in the sense that it contributes to the overall inflammatory burden that the patient is experiencing. And note that, in fact, the reservoir are damp buildings and noses of dogs. In addition to that, we now have a better tool to assess for the structural injury that occurs because of the ongoing inflammation in the central nervous system. This is the NeuroQuant, cleared in 2007 by the FDA. It's just a software program that MRI centers can license. It's very reproducible, originally designed for Alzheimer's and Parkinson's. We look at certain centers that relate to specific changes in the brain from exposure to biotoxins such as mold and Lyme. These are percent changes. Either they have interstitial edema, so volume enlargement, or volume loss related to atrophy or dendritic pruning. So CIRS really is something that once you get a handle on the diagnostic process and you say, oh my gosh, I have so many patients now that I've identified with this particular issue, your life is going to change. It's going to really help you better identify those individuals that have been suffering for so many years from these vague but persistent complaints. They're really debilitated in various ways. And now you finally have potentially a framework to diagnose them in a proper way and to capture all of these changes that are going on in their physiology. So what I just covered reflects a brief overview of part one of this subject, but now let's get into the treatment protocol. And so this really is a stepwise process to help unwind all of the issues related to this patient population. So you'll see I've laid this out in great detail. I do not want anybody guessing in terms of, what am I supposed to do? And a few caveats. The first is you should do this in order, in the sense that we know if you try and do everything at once with these patients, they're not going to progress. And it just gets to be overwhelming for both of you. So I suggest, following this process and sort of honoring the fact that there's a reason for why we have things in a certain order. So you can see that under foundations, you want to get your patients on a low inflammatory, low mold diet, begin to engage stress management techniques and sleep support. And one big area that becomes so important for these patients is to start replacing with healthy lipids. So lipid replacement is a key feature of getting these patients better. And it's because abnormal lipids begin to accrue in the cell membrane, and therefore their mitochondria are not working very well. There's poor cell-to-cell communication. Ceramides and lipid rafts are starting to form. And by virtue of this, the nervous system in particular, which is rich in these phospholipids, becomes impaired over time. So it's so critically important to start replacing with healthy phospholipids, which includes phosphatidylcholine, 1.8 grams twice a day, some high-quality fish oil, in addition to high-quality evening primrose oil, because you need the gamma-linolenic acid to help stabilize the membrane, in addition to wheat germ oil or polycosanol, which is actually a structural lipid. Now, that originally had been studied to lower cholesterol. Turns out it's a lipid itself, really critical for healthy membranes. So I always start all of my patients on all four of these items. In addition to that, we have to go after reducing the fire in the brain. Remember in part one, I said these patients, they just are experiencing so much neuroexcitation and neuroinflammation. This is a brain on fire phenomenon. So how do we start dealing with that? Well, we have to turn off the flames. Ginseng as an adaptogen is very good in helping us in that regard. Turns out a number of the adaptogens have that capacity. In addition to that, of course, curcumin or turmeric are also quite good as anti-inflammatories. Magnesium as well to help decrease that neuroexcitation. And then also, I think it's important for the body to begin to gently detoxify. So if you have access to some healthy powders, for example, that support detox, I think that's a really nice thing to do. And I'll talk a little bit more about why that is in a second. So once you start them on their foundation, some lifestyle support, lipids, and reducing neuroinflammation, and they're starting to feel a little bit better, then we go on to talking about, well, what is the exposure itself? Is it Lyme disease? Is it mold? How do we begin to contend with this issue? We have several options in that regard, although for the purposes of this talk, I'm not going to go over all of the strategies for how we get rid of Lyme disease. That's a whole separate issue. But I do want to raise it as an awareness factor. For mold, you want to have patients begin cleaning up their home. That's a HEPA vacuum cleaner, HEPA units throughout the home, and then photocatalytic air purifiers. And there's several companies that now have that on the market. Once you begin to initiate these exposure elimination tactics, then you can begin to work on reducing the toxin burden in the patient itself. And this comes in sort of three chunks. The first is dealing with further the neurologic inflammation. This has to do with the visual contrast test. The second is respiratory related inflammation because of the MARCoNS. And then the third is GI inflammation because of food sensitivities. So there's a whole process that we go through with this biotoxin management of sucking out this inflammation, and that has to actually be done through the digestive tract itself. So we use binders such as a prescribed cholestyramine, but also okra as a natural compound, works similarly to cholestyramine. It's just not as potent. Okra works better when you add fiber, and because they're binders that can suck out nutrients, you want your patients on a multivitamin and mineral. In addition to that, the mycotoxins, mold spores, and inflammatory proteins are trafficked through the bile. So we give some ox bile for support, and then also N-acetylcysteine to build glutathione reserves in the liver. We're doing all of this so the patient can pass the visual test. That is key and critical. You want to get them to the point where if they didn't pass it to begin with, they're able to pass it. So that way you're making progress. Once they pass their visual test, now we can take on another source of inflammation, which is the MARCoNS. If it's present because of the nasal swab, we get them on a special nasal spray, whether that's a compounded set of antibiotics, or you can do a silver with EDTA. Sprays also need to have some sort of component to break down biofilm. I like the EDTA. In addition to that, once they clear their MARCoNS, now we can go after the gut. And this is when we run our food panels, maybe do a functional GI test, and we add in something that's healing for the digestive tract and for cell membranes, and to help turn off and re-regulate the immune system, which is butyrate. Butyrate is a magical ingredient, really important for this illness in general. And I use quite a lot of butyrate in my practice. Once you're able to turn off these fires in the brain, in the respiratory tract, and then in the gut, you can go on to better balance their metabolism. That means they're probably ready for just regular detoxification as long as their pH is above 6.5. Then you can move on to some hormonal balancing, either through natural compounds, or you can do bioidentical hormone replacement. Once you do that for 6 weeks or so, we then go after water balance in these patients, and this is one of those steps where I just have not found a natural substitute. So if they're having water-related issues and they're hyperconcentrated, we use desmopressin 0.2 milligrams every other night for 7 doses, and that typically helps to re-regulate their water balance. Once we get through this fourth section, then we go to the fifth, which is resolution and repair. We go back to looking at some of those inflammatory proteins, so we remeasure MMP9. If it's elevated, we put patients on a low amylose diet, as well as boswellia. We then recheck their complement factors, C3 and C4A. If they're high, red yeast ice and CoQ10 and fish oils help with that. And then finally, the transcription factor, TGF-beta1, if that's high, resveratrol, L-carnitine work. And that brings us to the final step of therapy, which is the compounded VIP nasal spray, which corrects those genomic aberrations and heals the brain. So you can see there are really only, 3 areas where I've put in a prescribed medication: cholestyramine, the desmopressin, and the VIP. Hopefully the ochre works, which it often does, but not always. Oftentimes, by the moment you get to remeasuring ADH, usually that's gone back to normal without having to treat. So hopefully you can skip the desmopressin step. And then finally, VIP. We also know that VIP actually helps to correct the ADH issues. So you might not have to do that at all. You can potentially just skip that step and keep going. But ultimately then we finish with VIP, which is our special neuropeptide to correct the final issues. So this is your CIRS natural toolkit. I really want you to focus in on this. These are your tools that can make a big difference in this patient population. The lipid replacement, the strategies to turn off neuroinflammation, dealing a little bit with parasites and pathogens, in addition to draining the body of this inflammation with ochre and fiber and giving some bile support, eliminating the MARCons, and then turning off the final residual effects of inflammation with boswellia and resveratrol, which will ultimately lead you to the VIP. So let's review all of that in a little more detail. For foundations, you want to protect the brain. So lifestyle interventions, lipid replacement, and reducing neuroinflammation. So how do I turn off that fire? Turmeric is a wonderful, wonderful compound that has very potent anti-inflammatory properties. It's a close relative of ginger. It's a traditional Ayurvedic remedy. It has anti-inflammatory and antioxidant capacity. It's also been shown to help improve blood sugar control. It slows progression of renal issues as well as diabetic retinopathy, suppresses diabetic cataracts by preventing glycation, and then lowers cholesterol and triglycerides. The curcumin dose is 500 milligrams twice a day in OA, 400 milligrams 3 times a day in RA. There are high absorption forms as well, and you want to push it so that it gets across the blood-brain barrier. Some side effects, usually a little GI irritation, nothing much more than that. In addition, Eleutherococcus or Siberian ginseng. This is from a spiny stem shrub found in Northeast Asia and Japan. It's been prescribed in a lot of different botanical traditions: France, Germany, Russia, and China. And the parts used are the dried roots and the root bark. There are a variety of active constituents, including the eleutherocydes, as well as, and you'll find this in a lot of botanicals. The lignans are often important. The beta-cytosterols are important. And also the ginsenosides as a total family, which are components of the eleutherocydes. So those are the ones that are most potent in terms of turning off inflammation in the body, more generally in the brain in particular. So it has anti-inflammatory and neuroprotective effects. It prevents bone resorption during experimental steroid-induced osteoporosis. It can protect against hepatic failure. It's radioprotective for the bloodline. It also inhibits histamine release and increases concentration of biogenic amines. So noradrenaline and dopamine makes sense because it improves focus and concentration. So, adaptogens have been used for thousands of years and for good reason. It turns out many of them have wonderful neuroprotective qualities, and the ginseng in particular is quite potent in that regard. So 400 milligrams 3 times a day for preventing common cold, more generally 400 milligrams daily for chronic infections, for example, and that's what you'll be doing in the CIRS population as well. In addition to that, I know I've lectured on L-theanine related to the Da Vinci Education series. This is a green tea extract, historically been used for its anti-anxiety properties. It's an analog of glutamate. It binds to dopa and GABAamine receptors. It stabilizes NMDA, so it prevents calcium influx into the nerve cell. It also reduces norepi levels and decreases blood pressure, and even blocks the stimulatory effects of caffeine. This is a great product. It's super safe, even increases alpha wave states, which is a meditative-like state in the brain. It's non-sedating, but calming. So dosing in kids is 50 to 100 milligrams 2 to 3 times a day. In adults, it's 200 to 400 milligrams 3 times a day. Really good, because oftentimes patients who have CIRS, they have a lot of neuroexcitation, and theanine is quite efficient at reducing that. Then we go through the exposure elimination, and this has to do with getting rid of pathogens, as well as remediating the patient's living or working environment. HEPA units are really good, in addition to the new photocatalytic air purifiers for the home. I like to use Artemisia, which is basically wormwood. It's been shown to have good antiparasitic activity, which does include Babesia, which is one of the co-infections for Lyme disease. In the clinical trials, there have been several of them. Usually there's quick resolution. One of the nice features of wormwood is it gets into peripheral tissue and has very potent clinical effects in that regard. It's also been shown to have some anti-inflammatory properties, such as an osteoarthritis. So then we move on to reducing the toxin burden. And this is a really important step. And I will draw your attention to the fact that the inflammation that's generated, even though that's produced in the peripheral tissue, it circulates through the vascular system and ultimately makes its way to the liver and is emulsified in the bile and disposed of in the digestive tract through the biliary tree. So that means that one major interface between the body and this inflammation is the gut. And it turns out that one of the best ways to reduce that inflammatory burden is to literally bind to it and suck it out through the digestive tract. And so we have a couple options in that regard. We have cholestyramine, which is a anion resin binder. This is a prescription that was been used for many, many years to lower cholesterol, but it turns out okra has very similar properties. It's just not as potent. It doesn't have as many binding sites. So it's only 20 to 30% as effective. You can get a little more out of that if you add some soluble fiber, 11 grams per day. And again, don't forget, these binders will pull out nutrients, so you want to replace with a multivitamin and mineral, as well as facilitate smooth bile flow. So I like ox bile, 500 milligrams with meals, in addition to some direct liver support with N-acetylcysteine. All of this is meant to drain the body of this inflammation, and the brain in particular, so that they can pass their visual test. So you think about what you've done. You've given direct agents for the brain, like ginseng and curcumin and magnesium and lipids, and then you start cleaning up the source of the inflammation or the original trigger, whether that's a pathogen or mold or whatever it ends up being. Now the patient is prepped and ready to start draining the consequences of all of that, which is the inflammatory compounds that make their way into the gut. Once they're able to pass their visual test, then you swab their nose for the MARCoNS. If it's present, you'll do a nasal spray, either Bactroban EDTA or Bactroban EDTA gentamicin or EDTA in silver. You treat for 6 weeks, they wait a week, then they re-swab their nose. If and when they clear, then you move on to the third step, which is GI health. I know as a community, you all are excellent at treating the gut. You may want to do a food panel. Don't forget, low MSH leads to leaky gut and therefore predisposes to food sensitivities. In addition, you can also consider doing a functional GI test. And this is when I add in some butyrate, which feeds the gut lining, but is also really good at building resolvin and protectin levels, which help modulate the immune system. And they burn off abnormal fats in the cell membrane. So they clear out the mitochondria and get the biogenesis going again. So there's good ATP production. And patients are now really starting to feel better. You've cleaned up their diet, you've cleared out their respiratory tract, you've gotten them past the visual test. They are going to be doing really well by this point in terms of reducing their toxic burden. And therapeutically speaking, at this big third step, we're taking advantage of the enterohepatic circulation that's occurring because of the trafficking of the mycotoxins and inflammatory proteins. So again, we have a prescription option, which is the cholestyramine that functions as a binder. Think of it as glue. This is a really interesting resin that essentially has these polystyrene side chains that are positively charged, and they're able to bind onto these negatively charged anions that are the inflammatory compounds. And the receptor site is exquisitely positioned for this purpose because it's 1.43 angstroms in size, which is almost identical to parts of the biotoxin, which is 1.4 angstroms in size. Here's the research study that compared a variety of vegetable matters to cholestyramine as the standard, which showed, in fact, okra was 20 to 30% as effective, especially when you add fiber. In addition to that, here we have our friends, the Marcons, which can begin to establish an infection in the deep nasal passages. And a lot of times patients don't have sinus complaints. So that's the insidious component of this pathogen, is that it just quietly lays there in the deep nasal passages, making biofilm and then releasing what's called a paleotoxin directly into the central nervous system, which further inflames the brain. So we can prescribe BEG spray through your local compounding pharmacy. But if you're not able to do that, I suggest silver EDTA, which has also been proving to be very effective for these patients. It's quite good at clearing out Marcons as well. Don't forget, it's 6 weeks of treatment at least. If they don't clear after the first round, then you got to do another round of 4 to 6 weeks until they clear. Then we move on to the metabolic balance. This is a really important sequence of events. Now you can start detoxifying them of heavy metals and chemicals. I like chlorella, clay, okra, charcoal, zeolite, as well as all the factors that raise glutathione levels, or you can do topical glutathione. Do this for about 4 weeks or so. Let's start mobilizing those toxins from the deep tissues. Now they're ready for some hormone balancing. You can do this through things like chasteberry, or other botanicals that help balance hormones, or you can just do DHEA. That's proven to be very effective as part of this treatment protocol. For women, it's 5 to 25 milligrams. For men, it's 25 to 50. And you can sort of do full bore BHRT if you're able to do that. And then finally, we get to water balance issues. If they're not looking too bad and they're not urinating really frequently, they don't have POT symptoms, for example, you can get away with potentially skipping this step. There just is not a natural substitute for the desmopressin. But we also know by the time they get to the final step with VIP, that also helps to correct the ADH. And then we get to step 5, which is resolution and repair. And resolution and repair is so important because this is where we get the patient back to normal. So we remeasure MMP9 if it's above 332. We get them on a low amylose diet, and we can add in some boswellia, 400 milligrams 3 times per day. We then move on to remeasuring their complement levels, C3A, C4A. If they're still high, you can increase their dose of fish oil or add some CoQ10 or resolvins. Now, again, butyrate will do that very nicely for producing resolvins. Then you remeasure TGF-beta1. Bilberry helps here, carnitine helps here, resveratrol helps here, and then finally the VIP nasal spray. So here we have our low amylose diet. So amylose are basically found in root vegetables. They're comprised of simple sugars, maltodextrins, and corn syrup. So you want the patient to avoid wheat, rice, rye, barley, and oats. Look for gluten-free alternatives, avoid bananas, and look for hidden sugars. Boswellia is so good at blocking down on MMP9. This is a derivative of frankincense. It's a gum resin. It's been well studied in a variety of inflammatory conditions and is, I think, quite effective in CIRS as well. Dose is 400 milligrams 2 to 3 times per day. Resveratrol has also been shown to lower TGF-beta1. So I think this is a nice option for people if that one is still elevated, at least 100 to 200 milligrams daily. Now, don't forget, I had said, even if all the blood labs go to normal, the patient is not back to their regular state of health yet. And it's because of this ongoing genomic activity. So we know that in the new world of genomics, when we expose our gene sequences to a variety of stimuli, we get a response. This is the epigenetics, basically genes turning on and off. And the way we measure that is through transcriptomics, meaning what is the RNA that's being produced off of the DNA sequences. So the transcriptome is a very sensitive indicator of disease status and emerging health hazards. We collected data on 50 subjects who had gone through our treatment protocol, and we asked the question, they're pre-VIP, which genes are turned on and which are off. We looked expressly at the mitochondria at 900 genes, and what we found is that in our Lyme patients, 500 genes were turned on inappropriately, and in the mold population, 700 genes were turned on inappropriately. So there's overlap between the two to some degree, but there's abnormal gene expression as a result of the exposure. And what this means is the body just can't turn off its inflammation, that this is the engine that's driving the abnormalities. We color-coded the gene sequences, so anything that's turned on and upregulated that's abnormal is versions of orange and red, and then gene sequences that were downregulated and therefore normal are blue and purple. So we then administered the VIP nasal spray. There's a whole protocol for this as well. And this neuropeptide we already knew healed the brain. That was extraordinary that VIP did that, because it has very potent anti-inflammatory properties. It improved blood flow to the cerebral through the cerebral circulation. But we didn't know whether or not VIP did anything for these abnormal gene sequences. So we administered VIP for patients. We said, come back when you feel better. The average length of treatment was about 4 months. And patients said, oh my goodness, I can't believe it. I feel like my old self. And we said, okay, let's remeasure your genes and see what happens. And this is what happened. So we see a return to baseline of all this excess gene response, that in fact VIP induced re-regulation of gene activity. This was incredible to us, that not only did VIP heal the brain, it also returned the genes back to normal. So it's really critical in this patient population to administer VIP one way or the other. If you're able to prescribe it, great. If not, then you need to find a provider who can do this for you, because the patient is not cured until they're able to do VIP. Now, we're still looking for other treatments that are natural and over-the-counter that will do the same thing. Right now, the only thing that we have found to alter gene expression is VIP itself. So VIP causes changes in that gene regulation that's found in the mitochondria, and it helps to reduce the microbial toxins that are cleaved or modify ribosomal RNA at the sarsen-ricin loop. Basically, all of this is sort of our findings in terms of the problems that microbial toxins create with the DNA machinery. So not only are there direct epigenetic changes, but there's injury to the sarsen-ricin loop, there's injury to the ribosome because these are ribotoxins, and therefore the ribosomes are not able to produce proteins very efficiently. They have malfolded proteins, too many proteins. It's a mess in terms of their molecular chemistry. It's not really known how VIP is acting to influence the ribosome or the mitochondria. We don't understand its impact, but we can see the result. And the average length of treatment was 4 to 6 months or so. The dose is just 50 micrograms, 1 to 3 sprays in each nostril 4 times per day. And then we monitor patients every month or so to make sure that they're doing well. And if their labs weren't fully normal when we started VIP, we should see a return to baseline, including MMP9 and ADH and the rest. So this is your biotoxin evaluation process. It's a stepwise series of assessments to make the proper diagnosis, from the initial screening to verification and then supporting diagnostic strategies. Here we have the expanded treatment protocol, which includes the lipid replacement, turning off the fire in the brain, dealing with the exposures themselves, reducing their toxic burden, inducing metabolic balance, and then finally encouraging resolution and repair. So it's not one thing, it's lots of things that you need to do in a very specific order to get these patients better. But when you do, it is incredible. You know, these are individuals that have been sick for months and years. No one's ever been able to figure out what's really wrong with them. Oftentimes practitioners have been working around the edges. but now they're able to, now we're able to, give you a pathway forward to be able to return these patients to a normal baseline. This really is induction of a cure, which I think is great. And then here are your natural tools in that regard: the lipids, the anti-inflammatories, the ability to detoxify the gut in particular, clearing the Marcons, and then turning off the residual inflammation with the Boswellia and the resveratrol. And then the final is the VIP itself. So I hope you got a lot out of this. My goal was to make sure that this was concise, that you saw this as a stepwise process or protocol with discrete decision points along the way. You see the dosing, you see exactly how things are organized, so there shouldn't be a lot of guesswork for you in terms of how do I diagnose these patients and then how do I treat them. So thank you very much for your attention. I'm so excited to be able to share all this information with you. I hope this really helps you in your practices and moving forward and treating these complicated patients. And I know that you're going to go forward and do so well with this patient population. And I look forward to speaking with you once again in the future as part of the Da Vinci Education series.